Very good morning. Today, our class is on sequelae of pulpitis. Coming to the topic, we have the introduction, sequelae of pulpitis, focal reversible pulpitis, acute pulpitis, chronic pulpitis, chronic hyperplastic pulpitis, apical periodontitis, acute apical periodontitis, chronic apical periodontitis, apical periodontal cyst, periapical abscess, osteomyelitis. Under osteomyelitis, we have acute separative osteomyelitis, chronic separative osteomyelitis, chronic focal sclerosing osteomyelitis, chronic diffuse sclerosing osteomyelitis, chronic osteomyelitis with proliferating periostitis and conclusion. Then coming to the introduction, as we all know, dental pulp, it's a delicate connective tissue interspersed with tiny blood vessels, lymphatics, nerves, undifferentiated connective tissue cells, right? So as any connective tissue in the body, dental pulp also reacts to the irritants and infections by its inflammatory response. So the inflammatory response of the pulp is said to be pulpitis, and the pulpitis is responsible for the toothache or odontalgia. Then coming to the sequelae of pulpitis, so now we know that it is an inflammatory reaction of the pulp, that is the pulpitis, and there is acute pulpitis and chronic pulpitis, and this may lead to the periapical tissues, and then it becomes the apical periodontitis, right? Then acute and chronic pulpitis, sometimes it when the chronic grows to periapical granuloma, periapical cyst, periapical abscess, or sometimes acute pulpitis may directly goes in periapical abscess. Okay, and when this progress, it may affect the bone marrow, marrow spaces, and it will lead to osteomyelitis, and you have different types of osteomyelitis, and again, if it progresses, it will lead to cellulitis or abscess. Yeah, so first we have to study about the focal reversible pulpitis. So from the this thing also, we can identify this, it as reversible, right? Reversible means whenever we remove the irritant or the infective agent, then the pulp becomes normal. The inflammatory reaction will subside. That's the thing. So, coming to the clinical features in focal reversible pulpitis, it is sensitive to thermal changes. When we are eating hot food or cold food or something, it's sensitive to thermal changes. Then respond to electric pulp tester at low level of current, and it shows deep caries lesion or large metallic restorations with defective margin. Coming to the treatment, we have to remove the caries lesion, and or we have to remove the defective filling. That's about the reversible pulpitis. So in reversible pulpitis, teeth shows deep caries lesions or large metallic restorations with defective margins, and we have to remove the irritant. Then coming to the acute pulpitis. Acute pulpitis means it is the acute, extensive, acute inflammation of the dental pulp. It is the acute inflammation of the dental pulp. And coming to the etiology, it may be the sequelae of focal reversible pulpitis. Sometimes this focal reversible pulpitis, if we are not going for the treatment, then it becomes acute pulpitis. Or sometimes it may be the acute exacerbation of a chronic inflammatory process. Coming to the clinical features of acute pulpitis, it is large caries lesion or defective restoration with recurrent caries. And in acute pulpitis, the pain is severe and it is elicited by thermal changes. When we are eating hot food or cold food, there is severe pain, and the pain persists even after the thermal stimulus has disappeared. And the pulpal pain, it is poor. We can't localize the pain. Which tooth has the pain? We can't localize. It's like any teeth of upper and lower jaw affected side. And the pain is lacinating or throbbing type pain, and the pain lasts for 10 to 15 minutes. Intensity of pain increases when patient lies down. Sometimes the patient can't sleep at all. When the cavity is small, the pain will be more because pulp is enclosed within the walls of the dentine, and there is no space for the pressure to let it out, right? So if the pain is lacinating type of pain and it extends to the apex and it is sensitive to percussion. When large open cavity is present, some pressure release is there, no pressure built up, no rapid spread of inflammatory process, pain is dull, throbbing need, ache, mobility and sensitivity to percussion, absent. So that's about acute pulpitis. So we know about reversible pulpitis, and sometimes if not treated, it may lead to acute pulpitis. And the treatment includes the removal of the coronal pulp of the pulpotomy. And we have to apply calcium hydroxide that favors calcification over the entrance of the root canal. Otherwise, we have to fill the root canals with inert material provided pulp chamber and root canals can be sterilized. So either we have to remove the coronal pulp, we have to do the pulpotomy. Otherwise, we have to go for the filling of root canals. Next, coming to the chronic pulpitis. What is the etiology of chronic pulpitis? Quiescence of previous acute pulpitis. And it occurs as chronic type of disease from onset. Sometimes it may be chronic from the onset, or it may be a sequelae of this acute pulpitis. Pain is not a prominent feature, but in acute pulpitis, pain is a prominent feature, but in chronic pulpitis, pain is not a prominent feature. Mild dull ache. And pain often intermittent. There is intermittent type of pain than continuous, but in acute pulpitis, it is continuous. And reaction to thermal change reduced because a pulp may become totally necrotic. That's without the, we can't, there is no pain. Okay. And we have to go for root canal therapy. So chronic pulpitis is over. Then chronic hyperplastic pulpitis. It's a unique form of pulpitis. Here, the inflamed pulp, instead of perishing by continuous separation, it reacts by excessive and exuberant proliferation of the pulp. So there is the exuberant proliferation of the pulp, because in children and young adults, or the tissue resistance is more, the reactivity is more. So that times there is the exuberant proliferation of the pulpal tissue, and you can see the teeth with large open carious lesions. You can see the pulp, the proliferation of the pulpal tissue as a small globule over the occlusal surface. And the pulp appears as a pinkish red globule of tissue protruding from the pulp chamber. Mainly you can see in deciduous molars and first permanent molars, and you can call it as pulp polyp also. So chronic hyperplastic pulpitis or pulp polyp. You have to do the extraction of the tooth or pulp extraction. That is about chronic hyperplastic pulpitis. Next, coming to apical periodontitis. So whenever the infection or inflammation what goes beyond the pulpal tissue, it reaches the periapical tissues and it goes to the periodontium. That is, there is the inflammatory reaction of the periodontium, right? So that is the apical periodontitis. That is the inflammation of the periodontal ligament around the root apex. And there is resorption of the periapical bone and sometimes the root apex. It may be acute or chronic. Then coming to the etiology, there is, what happens is there is spread of infection following pulp necrosis. So after this pulp necrosis, there is the connection of the apical foramen and there is spread of infection and it goes to the periodontal ligament. And occlusal trauma from high restoration. Sometimes when we bite a stone, sometimes we will get a stone from the rice, right? So that time when we bite, maybe some kind of occlusal trauma for occlusal trauma. That time also the periodontitis will happen. And biting suddenly on a hard object or pushing infected material into the apical portion or chemical irritation from some root canal medicaments what we are giving. Okay. That is apical periodontitis. And apical periodontitis also we have acute apical periodontitis. That is, there is a history of previous pulpitis and thermal changes does not induce pain as in pulpitis. And sometimes we can feel the tooth is slightly elevated in its socket because of the collection of the inflammatory edema in the periodontal ligament. So in the periodontal ligament, there may be the collection of the inflammatory edema and you can feel the tooth is slightly elevated in its socket. And there is tenderness while biting. Even to mere touch, severe pain is there. So there is tenderness on biting, on percussion and all. We have that tenderness. And if inflammation caused by occlusal trauma, we have to reduce the occlusal surface. We can give the occlusal clearance. Then that occlusion, when we are biting that pain, we can reduce the pain. So if inflammation caused by occlusion trauma, relieved by selective occlusal grinding. If it is due to spread of pulpal infection, extraction or endodontic treatment to drain the exudate. That's about acute apical periodontitis. Then coming to the chronic apical periodontitis. So if we left it untreated, so it becomes chronic, right? And this chronic apical periodontitis, that is called a periapical granuloma. Okay, it is a type of low-grade infection. It is the most common sequelae of pulpitis. And it is a localized mass of chronic granulation tissue formed in response to infection. And the spread of infection usually in the periapical direction. So this is the periapical granuloma. What are the clinical features? Mostly the involved tooth is non-vital. And it is slightly tender on percussion. If it is so then percussion produces a dull sound and mild pain on biting or chewing. Mostly it may be non-vital, but in some cases it may be mild pain on biting or chewing. Then sensitivity is due to hyperemia, edema, and inflammation of the apical periodontal ligament. Then treatment includes extraction of the involved tooth, root canal therapy with or without subsequent epicosectomy. If left untreated, it may undergo transformation into apical periodontal cyst. So in the sequelae of pulpitis, we can see acute pulpitis, chronic pulpitis, then it comes to periodontitis, and when chronic apical periodontitis, it will go for this periapical granuloma, and this periapical granuloma, if left untreated, may go for the periapical cyst or the periodontal cyst. So that is the apical periodontal cyst. And it's the most common odontogenic cyst. So it's a kind of inflammatory cyst, right? So other names, radicular cyst, periapical cyst, root end cyst, and it is a result of bacterial infection and necrosis of dental pulp following caries. It is asymptomatic, mostly in 20 and 60 years of age. Maxillary anteriors followed by mandibular premolars and molars. The mouth is commonly affected and the tooth is non-vital. It shows deep caries lesion or a restoration which is seldom painful. Mostly in cases, tooth is non-vital. So that it is seldom painful. And treatment includes root canal therapy of involved tooth along with periapical surgery or extraction of the involved tooth followed by periapical curettage. Either extraction of the involved tooth followed by periapical curettage, or you have to go for root canal therapy along with periapical surgery. Then coming to the periapical abscess. So other names for periapical abscess is dento-alveolar abscess. Or then it is acute or chronic separative process of periapical region, and it develops from either acute periapical periodontitis or from a periapical granuloma. And acute exacerbation of chronic periapical lesion is known as sphinx abscess. So what is the sphinx abscess? It is some kind of exacerbation, acute exacerbation of a chronic periapical lesion. That is a sphinx abscess. And what are the clinical features of this periapical abscess? Acute periapical abscess, you have tenderness of tooth, extremely painful, slightly extruded from its socket, and rapid extension to adjacent. And when the periapical abscess comes, this may sometimes spread to the bone marrow spaces also. Okay, it produces osteomyelitis. And when coming to the chronic periapical abscess, no clinical features, since it is a mild, well-circumscribed area of separation that shows little tendency to spread from local area. So that is the periapical abscess. And the treatment includes, you have to do the drainage, opening the pulp chamber, or extracting the tooth. In some cases, tooth is retained and root canal therapy is carried out if the lesion can be sterilized. Okay. Then, so this periapical abscess, the pus may and the infection may spread to the narrow spaces, right? And it becomes osteomyelitis. And what is osteomyelitis? It is the inflammation of the bone and its narrow contents. And what are the predisposing factors? In some cases, it may easily lead to this osteomyelitis. Why? Because of some of the predisposing factors. Okay, fractures due to trauma, road traffic accidents, gunshot wounds, radiation damage, Peyer's disease, osteoporosis, and some kind of systemic conditions. Okay. And in first one, it is acute separative osteomyelitis. That is a sequelae of periapical infection. That is a diffuse spread of infection throughout the medullary spaces and subsequent necrosis of variable amount of bone. And after that, the bone will get necrotized, right? So it is polymicrobial. So many bacteria are involving in this osteomyelitis. And most common causes dental infection. Other causes, infection due to fracture of jaw, gunshot. In this case is also directly there is osteomyelitis, fracture of jaw, gunshot wounds, hematological spread. Okay. And when coming to the clinical features, maxilla it is localized and mandible it is diffuse. Because maxilla there is blood supply, collateral blood supply, but mandible it is diffuse and widespread. And it is severe pain. There is severe pain, trismus, and paresthesia of lips in case of mandibular involvement. There is elevation of temperature. Whatever features you can see in inflammation, you can see here also, and trismus may be there. Loosening of teeth and exudation of pus from gingiva. No swelling and redness till periostitis, Dept. Okay. Then coming to the treatment, you have to do the debridement or drainage, and you have to go on with the antimicrobial drugs. When intensity of the disease becomes attenuated, sequestrum begins to separate from the living bone. So sequestrum means the necrotized bone or the dead bone. Okay, begins to separate from the living bone. If the sequestrum is small, it exfoliates to the mucosa. If it is large, we have to do the surgical removal. Okay. Untreated cases may proceed to development of periostitis, soft tissue abscess, or cellulitis. Then coming to the chronic separative osteomyelitis, pain is less severe. In chronic cases, pain is less severe. Temperature is slightly elevated. Mucositis is slightly greater, and sometimes fistula tract may form, which opens towards the surface. And treatment, surgery with sustained bactericidal antibiotic therapy. Then coming to chronic focal sclerosing osteomyelitis or condensing osteitis. There is unusual reaction of bone to infection. Then high degree of tissue resistance and tissue reactivity. It's mostly in young adults and children. Mandibular molars are commonly affected. Symptoms mild pain due to infected pulp. Treatment includes extraction or endodontic treatment. That is chronic focal sclerosing osteomyelitis. Then chronic diffuse sclerosing osteomyelitis. There is proliferative reaction of bone to low-grade infection. And there is clinical, what are the clinical features in chronic diffuse sclerosing osteomyelitis? Occur at any age, more predominance in older age group, and it is common in the mandible and insidious in nature, no clinical indication of its presence. Acute exacerbations result in vague pain, unpleasant taste, mild separation, many times drainage through fistulous tract. So in chronic cases, fistula may form. And the treatment include lesion is too extensive to be removed surgically. Sclerotic bone, it is hypovascular and resistant to antibiotics. Extraction by surgical approach with removal of liberal amounts of bone to facilitate increased bleeding. Antibiotic administration during acute exacerbation may occur. And then coming to the chronic osteomyelitis with proliferative periostitis. There is focal gross thickening of periosteum with peripheral reactive bone formation resulting from mild reaction or infection. So there is peripheral reactive wound formation. And what are the clinical features? You can see it is commonly seen in children and young adults. You can see in mandible, bicuspid and molar region is affected, toothache and or pain in the jaws, and there is bony hard swelling on outer surface of the jaw. And what is the treatment? It is extraction or endodontic treatment. Then coming to the conclusion, there is establishment of proper diagnosis is of utmost importance to carry out the effective clinical procedure for the benefit of the patient. Review after treatment is also to be given importance. So that's all about sequelae of pulpitis. So pulpitis, periodontitis, then this may lead to, in chronic cases, this may lead to periapical granuloma, periapical cyst, periapical abscess, then it may lead to osteomyelitis. Okay, thank you.